Good morning, good afternoon, good evening, wherever this video finds you. I hope you are all doing well. Welcome to week 2 wrap up. Had a good week this week. I like some of the things I saw, different from week 1. I can definitely see that we're progressing as a group as far as our clinical reasoning and thinking, and we're starting to bring in some more literature. I liked what I saw in regards to people utilizing the Dropbox and putting in more articles and using it to support their thought process. That's really what this is about, getting us all to think a little bit deeper. And obviously I still think we've got room to grow, but we're definitely headed down the right path. So good work. Okay, so in regards to the HIPOA, the Handel article, a great article. Talking about there's a lot of discussion about grades of mobilization, discussion about thrust versus non-thrust. It sounds like some people are a little bit hesitant to thrust, that might be too aggressive. There's a number of different threads that were discussing that, and I just can't. I thrust hips all the time. Never had anybody have any problem with that. If you read the Hoeksema article, I know that wasn't a sign, but it also talks about the safety that goes along with that. In regards to in the Handel article, I think what's important to realize is that was a treatment package, and you're going to see more and more of this kind. Well, we see this in a variety of different areas. Treatment packages given to a group of people who have a certain condition, and then within that treatment package there are adjustments made, grades of mobilization, aggressiveness with what you do as far as your approach. But this treatment package, this concept of kind of combining manual therapy and exercise into one and then moving forward with a group of people is very common. And it works well. And for the hip, it's just, man, it's a home run. These people do really well with what we have. We certainly can help a lot of people who immediately think of hip replacements, and they needn't. The nerve entrapment stuff was really good. Hopefully everybody had an opportunity to kind of rethink their evaluation and to begin to incorporate some lower extremity nerve assessment if you weren't. And believe me, when the weekend intensive comes around, it's going to get more comprehensive. So you'll have lots of maybe some more options. I find that there's nerve entrapment stuff is an easy get sometimes because there are so many different venues in which nerve tissue can get hung up and ways to go at it, and can really make a significant difference. I just wanted to mention a couple of articles that were not part of the required reading, but that I find to be kind of staples in my pool of articles that when I'm working with students or other residents and fellows, that I refer to them, or when I'm teaching at University of Minnesota. The McDonald article, I think, Cameron was a mentor of mine. I think that's another great case series that gives you a few more options from a mobilization. Some of his stuff is a little bit different. The 2-person hip mob with inferior glide is really good. His prone stuff is good. So if you looking for other things, check that article out. I think the Hoeksema article on thrust is really good. I've already kind of alluded to that. And then make sure you know the Altman criteria. I know it was certainly talked about, and Hando used it in his stuff, but I think that's important to know. That's something that, if you don't already know it, you should have that written down somewhere, because you should be referencing that with your hip patients. Okay, so buttock pain, the Vosduven article that talked about the origins of buttock pain, SIJ, lumbar spine, hip. We're going to speak more to that because I think there's a bit of a misnomer that goes on about bursitis and lateral hip structures, and we're going to speak more to that in the coming weeks. Greater trochanteric pain syndrome or tendinopathy. We're going to get away from terms like bursitis because they're really kind of old school thinking. Inflammatory responses are being questioned kind of right and left, and things are more of an osis than they are an itis, and tendinopathy becomes much more omnipresent. But definitely buttock pain is a big deal, and not all hip or buttock regional pain is directly coming from the hip per se. That's why going into the lumbar spine and teasing that out and making sure things are good there, making a good neural nerve screen assessment, slump sitting, straight leg raise with dorsiflexion, and then screening out further from there. Those are all good things to tease out. And then even maybe understanding the cluster of SIJ tests to help perhaps tease in or tease out if that would be there. And again, we can debate about the efficacy of SIJ testing and whether that's really legitimate or not. And ultimately, the treatment ends up being similar and that you should just manipulate it. That some of the other palpatory treatments, or the palpatory diagnostics that go along with some of the pelvic or SIJ related things have been, really don't have any validity to them. Palpatory diagnosis as a general rule is not great. Even there was some discussion about dry needling, and I needle, but man, we have a hard time coming up with agreement. And so it's oftentimes looking for common structures or common things that we can all kind of put in a bucket. Common symptoms, common signs is usually the best way to go. Iliotibial band pain syndrome, the research is not great. And as you can see, the article kind of alluded to that. There was a couple of tests that they recommended that, had questionable reliability. Nobles and Renee, really nothing. Olbers had good reliability, but the validity just wasn't there. Some people mentioned that they were surprised at the poor research on iliotibial band. There really isn't a lot out there, and yet we see this problem fairly regularly, and so we probably need to have a more comprehensive package or program in place, and that would be another great place for research. So points of discussion, things as I was looking through all the posts this week that I thought were of interest and worthy to bring up. So outcomes, a lot of people seem to use a lot of the same tests. LEFS is very popular. Harris Hip Score is popular. Obviously, a lot of people are using photo, sit to stand. My apologies for that spelling error. And then the time to get up and go. A lot of people like the sit to stand, and it is a very simple test to use. It's very reliable. It has good numbers on it. Time to up and go is also one that's fairly simple to use. Doesn't require, a significant amount of space or equipment, and so everybody seemed to have a pretty good handle on these outcomes that they could look at, and then were retestable. Again, getting back to the iliotibial band, lack of research, importance of strengthening glute med. Everybody agreed that, getting that butt strong is a big deal, right? That was a common theme. There's some interesting discussion on the biomechanics of SFMA. I like the discussion. I like it. There was one of the groups that I'm with it was Dane and Zach had a really great exchange of ideas and thoughts. I'm not totally on board with it, but I love the discussion, and I would never get in the way of the critical thinking, and I appreciate the banter. So, and in the biomechanics thought process is that if we don't correct everything does it lead to something, right? Does it lead to a pain state, or does it lead to arthritis? We know that lots of things cause arthritis over a period of time. Arthritis is a natural aging process, right? That everybody gets arthritis. Some people get it more, some people get it less. But not everybody has pain. Why do some people have pain and some people don't? There's all these questions that kind of go into that. My concern is always about fear. Like if we're instilling fear and, you're doing this is going to lead to this, you've already caused damage. Does that create this unnecessary fear so that we don't want people doing things out of fear. We want people doing things out of this desire to feel better. And so my question is always like, how are we explaining this? And ultimately, if we just have a theoretical construct, or do we really know what's really going to be happening? Because many things change. People talking about dry needling techniques. Again, I'm a needler. I needle. I don't needle. I certainly don't needle everybody, but I probably needle a couple of times a day my patients, and I like the exchange of how people are needling or what they do with that, and what they think is actually happening. That whole thing is still a work in progress, and There'll be a lot more research to come. The research out right now is okay, but it's not, it's not bedrock by any means. But it's better than some stuff, that's for sure. You have to be careful not to stand too tall on that research, but it makes for good fodder. And then there was a really good exchange with Aaron, and now I'm forgetting who Aaron was exchanging a dialogue with in regards to dosing of exercise, and I thought that was. I enjoyed the concepts of what strength versus endurance, how hard should we be pushing, what are we really accomplishing, understanding that like in the Hando article what they were doing in regards to dosing and how many reps, and what are we trying to accomplish with our exercise program. Are we trying to build strength? Are we really building or endurance, or are we building these neural connections? The talk of, we know that strength gains or hypertrophy doesn't occur for 6 to 12 weeks after initiating an exercise program. So any gains that we see in those first 6 weeks have really nothing to do with muscle mass, right? It has everything to do with that building that bridge, better communication, a more efficient use, if you will. And so that was good discussion. I love that. Okay, week 3, FAI, labral tears, and groin pain. We'll talk about, continue with the great discussions. The fellowships discussions are going to be taking place. And look for a couple of other videos. I want to make sure that everybody's got this Dropbox thing down. And I'm going to probably try to get everybody to do a nesting of their posts. And I'll pass along another video to follow with that too. Hope you all have a great week. It was good reading your stuff. Continue to push yourself to be more critical in your thinking, supportive with literature, or be open and honest and say, this really doesn't have anything behind it, but this is my opinion, or this is what I see in the clinic. Nothing wrong with that. Nothing wrong with that, as long as we're honest about really where the information comes from, and then how hard or how much emphasis we can place upon it. Take good care to all. We'll see you next week.